welcome everybody, especially digitally, but also here on the Kettenbach stand. Thank you guys for inviting me to give a small tip, a small lecture about how we can use analog things in a digital workflow, because that's basically the topic of today. So the topic is centric in the digital age, and when it comes to things such as centric relation and centric in general and occlusion, a lot of people have a hard time understanding what it exactly is. So it's my job in the next 15 minutes to take you on a little journey and why I think it is really mandatory and super interesting to have a little bit of knowledge in this whole centric occlusion thing. So who am I? I'm Jasper. I'm a prosthodontist from the Netherlands. I'm a prosthodontist by the NVRT and EPA, and I have my own clinic in Oostenrijk, which is in the south of Holland. And we mainly do referral dentistry. I would say 90% of the work we do is referral dentistry. And one of my educational platforms is called Kaige Dentistry, which is kind of big platform. We are active in 144 countries. We are educated over 8,000 dentists, and we have a really cool group of ambassadors. And together we try to basically make dentistry fun again, sexy again. So when it comes to making kinetology sexy, this is usually how we think about kinetology. We find it kind of boring, and I mean, when I was in university and people were telling me about kinetology, I didn't find it was really sexy at all. Right? So in my opinion, kinetology is sexy and everybody should know about it, and every GP should at least have a little bit of knowledge about kinetology in the first place. So when it comes to centric, a lot of people have a hard time understanding what it really is. While centric and central occlusion it's not that hard to understand. It starts with understanding that everything that we do in dentistry, we should envision this from a holistic point of view, right? So it's not always about only looking to teeth. I'm a little dead on that myself. I have a few microscopes, I have these big loops, and I tend to deep dive into dentistry and into teeth themselves. But sometimes we forget that everything that we are doing in dentistry, it's just a part of the bigger system, right? It's a smaller part of the bigger system. So understanding how the upper jaw and the lower jaw are combined together and how they move together is kind of interesting. And one of the articles that I find really interesting is this one. It's an article by Charles Green. And Charles is really good in explaining what is centric, why is centric so important, right? But it starts all with the definition of what is centric and central occlusion in the first place. Well, in time, there have been numerous explanations about centric and centric relation and centric occlusion. But the most modern one is not that hard, right? Usually, the way I was taught about centric and central occlusion is that we would push the jaw up and backwards, right? But if we do that, then we are positioning the jaw in a way that is not really a good position for the lower jaw and the upper jaw, right? So what I think is interesting is the modern way we look at centric right now is like upper and to the front. And the reason why is because it makes a rotational movement. And this rotational movement is the starting point of how the jaw opens and closes. So when are we working in centric? It's really easy to understand. It's about, every time we have to work in centric, it's about occlusal reorganization, which basically is in the types of a full rehabilitation, full prosthesis, and orthodontics. While if we do orthodontics, and especially digital aligner orthodontics, not that many people work in centric, and it's a mistake because there's no reference when we are moving teeth through the bony housing, and we should find reference points where we can go back to and where we start with our treatment plans. So understanding the whole human skull and the way the upper jaw and the lower jaw move together is interesting. And there's this little figure which I found really interesting in university, but also kind of boring when I was in university because I didn't really understand what it was. So again, we tried to make kinetology sexy again, but it starts with understanding how the upper jaw and the lower jaw are actually moving together, right? So if we take a look to this figure, also envelope of motion figure, then we see that you see all these little points, you see all the little explanations, and these three are the most important ones, right? There's ICP, it's what we taught ourselves in how we should close the upper and the lower jaw. Then there's RCP, which is the retruded contact position, which is like the centric occlusion. It's when the lower jaw actually closes to the upper jaw. That's the first point that we make contact. And then there's centric. And a lot of people think centric is a certain point, while centric is just a little movement of the upper and the lower jaw in rotation, right? So I guess the most people define centric and using centric in this type of cases. It's a difficult type of case, right? Full rehabilitation, this is how we start. It's difficult because we see the upper and the lower jaw, they're not positioned right together. Eventually we see like a few differences in midlines. So this guy went into orthodontic surgery and ortho. And it was a 2.5 year period. He went to the orthodontic surgeon, he went to the orthodontist, and then he came back to the clinic. And the question was, please make it restoratively, finalize everything restoratively. And this is my starting point now. So why is this important? Because the question is, please finish this case with restorative, while the whole starting point still is not really right. Right? If you take a look at how the midline is shifted, still is shifted. It's even worse after the orthodontic surgery than before. And if you take to the left and we take a look to the right, we still see this midline shift is really crazy. And it's hard to make something from a restorative point of view, right? So we have to do something here. And the first step we take is find centric. And the reason why is because in finding centric, we can compensate restoratively in what we should have done orthodontically and orthodontic surgery. So eventually we finalize everything. But the most important part is this one, right? This is the occlusion. And here we see how this person bites in his maximum occlusion and what his position is in centric, which are two very different positions. But this is kind of complicated dentistry, and it's not for the everyday dentist. While I believe centric and the understanding of centric should be for the everyday dentist, right? So take a look at this guy. This is like the person that we see quite a lot in the clinic. You see it to his muscles. This is somebody that really clenches his jaws together. And if we take a look on how the teeth are actually eroded and are grinded off, right, this is stuff that we see every day. We see the lowers are grinded off. We see from the palatal side, we see that there's a lot of stuff grinded off. And the big question is, okay, how can we actually remake this? How can we restore this? And it's difficult because our starting position is not right, right? The reason why this is all happening is because the lower jaw and the upper jaw are actually not fitting together. So then we speak about a restricted or a constricted envelope of function. But if we want to restore this, we first have to define the centric and the rotational movement of the upper and the lower jaw before we even do something. And this is somebody who has like exactly the same problem, right? You're literally seeing this person clenching the upper and the lower jaw together with no space at all. And this person is in a lot of pain, back pain, neck pain, headaches, everything. And what happened is that this person did ortho, but only in the upper jaw. So what happens is the upper jaw was actually constricted. So the lower jaw had no room to fit into it. So what is the solution? It's actually also pretty easy. We define centric, and then we just retrude the lowers a little bit to make space for the lower jaw to move in the upper jaw, right? And again, this is all pretty much everyday dentistry because this kind of problems we face this as general practitioners. And if we take a look on the other, I guess, really important thing about centric and posture, but take a look to this picture. You see on the left, you see somebody standing up straight. And to the right, you see somebody with a leaf gauge, which is a little device where we can guide the lower jaw and the upper jaw. So now I suppose these two pictures together and take a look on the difference in the posture. So in our clinic, we do quite a lot of top athletes and Olympic sporters. And there's research that sometimes if you adjust occlusion and you make sure the lower jaw is fitting the upper jaw correctly in centric, so all the muscles have the right dimensions and the right length, there's some people and some sporters are actually performing to 20% better, which I find mind-blowing. And on the other hand, it's pretty logical at all when you take a look to this picture, because this person is literally going to stand straight when the lower jaw is positioned correctly to the upper jaw, right? And this, again, this is everyday dentistry. So this was the full rehab that I just showed you. But again, let's go back to ortho. Because when you take a look around here in the IDS, there's a lot of aligner providers. And a lot of aligner providers are starting from maximum occlusion, right? But you tell me, which starting point should I use? Because to the left, you see the maximum occlusion. And to the right, you see the centric. And if we are going to change everything, so if you're going to do a full occlusal rehabilitation, a reorganization, there should be some point we start to work in, and maximum occlusion is not the one, right? So I guess I'm a firm believer we should do all the ortho from a centric position, because that's a position that we always can go back to. So understanding this upper and this lower jaw movement and the relationship between the two of them it's super important, and it's quite interesting to have this knowledge as a GP. So communication-wise, this was for a long time what we did, right? We made wax-up models, we had the stone cast models in the articulator, and we did everything with the analog workflow. So this is how we did, and we started to find Centric in analog time. So we just had like the lower jaw positioned with a wax bite to the upper jaw, and then we used the models to put them in the articulator. And there was a lot of room for error in that. But now, as we look around here in the IDS, it's the time of digital dentistry. Right? There's a lot of really cool digital dentistry around, and this is how we do it in the clinic right now. Right? So we have some sensors, and digitally we are actually recording how the upper and the lower jaw are moving together. And it's not like a somewhere in between or AI movement or whatever. No, this is the actual movement of the patient. Right? However, this kind of technology and these devices are pretty, yeah, I guess we're pretty expensive. So it's not for the everyday practitioner. While a scanner nowadays is for the everyday practitioner. And the little tip I wanted to give is how to use a scanner and still record this centric relation from a digital perspective. So it all starts with making scans, right? And I guess I don't have to explain how you make scans. You make a scan from the upper jaw and you make a scan from the lower jaw. And from that point, you start to find centric. And one of the devices that I find really handy is called a leaf gauge. And a leaf gauge is a little piece of paper that you can vary with in thickness. So the thing that you're doing, you're guiding the upper and the lower jaw in the thickness of this little paper. And you're doing this until the moment you find central occlusion. So it's the first contact that you are having while closing the jaw. And this is exactly where a lot of mistakes are being made with scanning. I mean, a scanner is a pretty big thing, right? So as soon as you want to record this position, a lot of times you take the jaw with you, which actually means that you are moving the lower jaw to the upper jaw. And I don't want any recording with approximately this is the position, or I want the exact position. So one of the things that we then do is we use FUTA to record and to stabilize the bite. And when you're recording centric, this is a handy trick because now you can just scan whatever you want, right? You use FUTA to stabilize the bite, and now you can take the scanner and scan the posteriors so you have an accurate scanning. And it's not that hard, it's super easy. Because now you see like the lower jaw and the upper jaw, they are stabilized and you can scan whatever you want. And in those scans, after you scan it, you can analyze. You can do this on your scanner, you can do this on SmileCloud, you can do this in like a lot of different software programs. And you can analyze your models and you can see, so is there something different between maximum occlusion and centric relation? And usually those two don't fit together, right? So is this a problem? Do you always have to go in maximum occlusion centric relation? Should they be the same? And the answer is no, they don't, because a lot of people have different positions in this. As long as it's not pathological, if there's no problems, you can leave it as it is. But as soon as there are any complaints and pain or discomfort, and you don't know where the problem is, it can be really interesting to record centric and to compare this with the maximum occlusion, right? And again, when you're working in any occlusal reorganization, which is a full prosthesis in orthodontics or a full rehabilitation, it is really smart to work in centric and take that as your starting position, because it's a position that you can always go back to. So the main message I wanted to give today is that in all the violence of digital dentistry that we see around here on the IDS and that we use in the clinic, because I would say 98% of the work we do is all fully digital, with milling, with printing, with everything, with AI, with movement. We try to combine it all together. That sometimes you still need some analog things and analog tricks to make your digital dentistry more beneficial. And with that, I want to thank Ardi and the Kettenbach team for giving me the space to tell you a little bit about Centric in the digital age. And I wish you all a great IDS and a great fair. Thank you.